Hello, please, can everyone hear me? Good afternoon.
Good afternoon, we can hear you.
I'm sorry, I'm in a function. But please, Professor Karawema, please, ma, can you try to share your screen? And please, can we try to see if your audio is good, ma? We just want to try, ma. Dr. Aderomu, is your audio good?
Yes. Can you hear me? Am I audible? I think my audio is
Yes,
good.
you're audible. I can hear you clearly. Great.
Okay. Thank you.
Can you hear me?
Good afternoon, ma.
Dr. Kemi is not yet on the call. Please, I have to get up and call him.
Okay.
Hello,
yes.
Tokumbo, can you hear me?
Yes, Prof. Good afternoon, ma.
Good afternoon.
Yes, ma.
You want me to share my screen? Sure.
Yes, ma. We just want to see that it's possible. I don't know if I need to do anything or if the host needs to do anything to enable you to do that, ma.
Let me do it. Okay, just enable me.
Okay, ma. Dr. Basi, you are the host. Please, you have to enable Prof to share her screen.
Good evening, Prof. You can go ahead and share.
All right. Cyril, how are you?
Very fine, man. Good evening, man. Congratulations on your election.
Yeah, I think that must be it. Am I there? Can you see me?
Yes, Prof, we can see. Good afternoon.
Okay. So I have to stop sharing.
Yes, ma'am.
Okay.
Thank you, ma. It's great, ma.
Okay, you're already on. I wanted to be sure.
All right.
Dr. Kemi should please try to. Dr. Kemi, good afternoon, sir.
Good afternoon, everybody.
Yes, good afternoon, sir. We want you to try to share your screen. We want to see if it's good. The host will enable you to share.
Okay. Actually, my system is having some issues, so I'm just using my handset. I've sent the presentation to you already now.
To me?
Yes, on your WhatsApp, so that you can help me out.
I'm not to attend the meeting. I'm in a function.
Okay. Okay, let me send it to Cyril.
Yeah, send it to me. Send it.
All right.
Okay, Dr. Basi, will you be able to project it for him? Will you be able to share for him?
Yes, I will. That's no problem.
Thank you. Thank you so much.
Good afternoon, Professor Akaraiwe. Thank you so much. Well done, ma. Good afternoon, everyone.
Good afternoon, President.
Good afternoon, ma. Chair, well done.
Thank you, ma. We look forward to a beautiful webinar.
Thank God. Yeah, well done, well done.
Dr. Cyril, you can check now. Okay.
Yeah, I'm working on it. It will be up in a few minutes.
Okay.
All right. So, Dr. Deji, this is your presentation, yes? Hello, Dr. Kinyemi. Dr. Kinyemi, I think you are muted. You are trying to speak.
He needs to unmute himself.
Yeah.
Dr. Basi, please, I would like to find out, are we starting on the dot of 4 or we're going to allow a few minutes?
I'm waiting for that. Dr. Aderomo and Prof. Would let us know. Once we are set, we should be able to start. I'm just going to be at the background running the technical side of things. Dr. Aderomo would be the person moderating.
It's Dr. Aderomo.
Yeah, she's here. She's with us. Dr. Aderomo.
Yes, sir. I can hear you. I'm the one asking the question.
She's the one speaking.
Oh, your voice sounds like Rosola's voice. I thought.
Professor Lawe, good afternoon, ma.
Good afternoon, Dr. Aderomo.
Yes, ma.
Oh, wow.
So, the thing is, let's know the number of people there right now who have logged on. And then you just wait until you have a sizable number to start. Usually not more than 5 minutes.
Okay, ma. Thank you, ma.
Dr. Aderomo, you can welcome everyone at 4 p.m. and just wait for 2 to 3 minutes and start.
Okay, ma. Yes, ma'am.
And this is just to notify everyone that once the meeting starts, this meeting will be recorded. And please, if we have any concern about the meeting being recorded, kindly reach out to me privately so that we can address it. Thank you very much.
Good afternoon, everyone, and a warm welcome to the first in a series of webinars to celebrate the World Glaucoma Week 2025, organized by Glaucoma Society of Nigeria under the able leadership of the President, Professor Olushola Alawaye. My name is Aziza Aderomo. I'm a consultant ophthalmologist and a glaucoma specialist at the Obafemi Awolowo University Teaching Hospital, Ile-Ife in Osun State, and I'll be your moderator for today. The theme for World Glaucoma Week 2025 is Uniting for a Glaucoma-Free World. And to ensure this, we need to continue to spread awareness for glaucoma to enable early diagnosis. As a result of this afternoon, we have speakers that will be talking to us about the novel methods of screening for glaucoma. And in a few minutes, I'll be introducing who our speakers are to everybody on the platform. While we wait to allow more people to join us, I would like to recognize the presence of our esteemed professors on the platform here today. We're saying a warm welcome to you all. To my very distinguished senior colleagues, thank you for being here today and taking time out to be a part of this webinar. I will shortly be introducing who our speakers are. I would like to recognize the presence of the President of the Glaucoma Society of Nigeria once again. She's on the platform as well. Professor Olushola Olawaye, you're welcome, ma'am.
Thank you.
Please permit me to wait for about 5 minutes before we kick off the presentation of our speakers to allow more people to join. Thank you. It is 4:05, and at this point, I would like to warmly welcome our speakers to the platform today. I have the privilege today of introducing our excellent lineup of speakers for today, and they are experts in the field of ophthalmology and in particular in the field of glaucoma. And I would like you to join me to warmly welcome the first speaker. The first speaker is Dr. Akinyemi Adedeji. Dr. Akinyemi had his medical training at the University of Ibadan. He's also a fellow of the West African College of Surgeons and a fellow of the National Postgraduate Medical College of Nigeria. He's a certified glaucoma specialist and he trained at the Aravind Eye Hospital in India. He is a fellow of the Corporate Affairs Institute. He is the chief consultant ophthalmologist and the head of glaucoma services at the Federal Medical Center, Asaba, a position which he has held for over 10 decades now. He was the former HOD of ophthalmology at the Federal Medical Center, Asaba, a position he also held for about 10 years. As a result of his outstanding surgical skills and management qualities, he is one of the regular trainers at the Advanced Glaucoma course designed for consultant ophthalmologists in teaching institutions. He is an astute researcher, and he was formerly the public relations officer of the Glaucoma Society of Nigeria, and is currently the financial secretary of the Glaucoma Society of Nigeria. A big welcome to you, sir. I also have the pleasure to introduce the second speaker, an erudite scholar, a trainer of trainers. She is Professor Nkiru Kizo Akaraiwe. She is a consultant ophthalmologist and a glaucoma specialist. She was the foundation HOD and the head glaucoma services at the Department of Ophthalmology, Enugu State University Teaching Hospital, Parkland, Enugu. She is a professor of ophthalmology at the College of Medicine, Enugu State University. She is the current chairman of the Southeast Forum of Ophthalmologists, as well as the current and newly elected chairman of the Faculty of Ophthalmology, West African College of Surgeons. She is currently the governor representing Africa at the World Glaucoma Association. And I can tell that you would agree with me that we have an excellent lineup of speakers, and we look forward to them sharing their insightful knowledge with us. At this juncture, I'd like to hand over to Dr. Akinyemi and ask him to please share his screen and go ahead and start the presentation. Thank you, sir.
All right. Good evening, everybody. The chairman of Glaucoma Society of Nigeria, my senior colleagues, my colleagues, general ophthalmologists, glaucoma specialists, trainers of trainers there, and everybody. I want to really appreciate the Glaucoma Society of Nigeria and then Ophthalmological Society of Nigeria for giving me this privilege to be able to present this topic today. Can we hear me, please?
You are audible.
All right, thank you very much.
You are skipping rules. Please, if you're
Not quite loud.
Not quite loud. Can you hear me better now?
Yes, we can hear you, sir.
Somehow.
Okay, Sim is only the moderator that is hearing me well.
Yeah.
I
Okay,
think
let
it's
me just try
audible.
and make it.
Please check your audio if you're not hearing him well.
Okay,
Dr. Oba,
increase your...
please, can you hear him properly?
Dr. Cyril, can you hear me? Can everybody hear me?
I can hear you very well.
All right. Okay, so
Yeah.
please adjust your audio so that you can hear me very, very well. So today we are looking at the novel methods of screening for glaucoma, and it's part of our commemoration of World Glaucoma Week 2025 that is starting next week. And the theme for this year is Uniting for a Glaucoma-Free World. Let's have the slides roll, please. Okay, so we are uniting for a glaucoma-free world, as we see in the next slide. I have no financial attachment to this presentation, and I want a special acknowledgement to Dr. Vijaya that was supposed to, give us one of the lectures there. Some of these slides were actually from the work that she did and was supposed to be presented during the last Ophthalmological Society of Nigeria conference at Enugu. So acknowledgement for those works. All right, so I'll go through this outline in discussing the first aspect and the first segment of our presentation today. Glaucoma, like we know, is a group of diseases with characteristic optic nerve head and retinal nerve fiber layer changes and definitive visual field changes. And raised intraocular pressure will remain the only modifiable factor that we know. It's the second commonest cause of blindness, not only worldwide, but also in Nigeria as our own country. We know that more than 70 million people are affected worldwide, with approximately 10% of them being bilaterally blind. That's significant for us. The prevalence and the incidence of glaucoma are highest in the African nations, and Nigeria happens to be one of those countries. So it's not something that we should take lightly, and the prevalence of 5.02% and blindness prevalence of 0.7% in Nigeria is something that should bother us, and we should be ready to do everything possible to make sure that we curb it. I will also want to say here that 90% of people with glaucoma, they are undiagnosed in most developing countries. And this is as opposed to what we have in major developed countries where the percentage is just between 40 and 60. So we are still a way behind in terms of our ability to diagnose whether somebody has glaucoma or not. And population level surveys suggest that only 10 to 50% of people with glaucoma are actually aware that they have this disease. And then the remaining 50% to almost 90% are not aware. The high prevalence associated with glaucoma and is as a result of the early onset, the aggressive course, and limited resources for managing for management increases the blindness rates in most of the parts of sub-Saharan Africa. So early detection, early identification, and intervention are very, very critical to us in preventing the vision loss that results from glaucoma. The high rate of undiagnosed glaucoma causes significant blindness, and targeted screening has been found to be a help in early detection of glaucoma. And that's why it's not surprising that our topic today is talking about the fact that we need to devise and look out for more noble ways and novel ways of diagnosing glaucoma to those people that are usually not within our reach. The creation of awareness and appropriate screening activities have been found as important components of glaucoma care. So I'll just quickly talk about the concept of screening before we look at glaucoma screening itself and the things that we have to do on this first part of the presentation. When we talk about screening, we're just looking at the processes by which we want to identify potential health conditions and diseases. In this case today, we're talking about glaucoma, especially in individuals that are at risk for that condition, but long before the symptoms appear in them. A lot of importance of screening, the significance, the reasons why you want to screen. It fosters early detection, prevention, risk reduction, and better management in order to improve the health outcomes that we get from such diseases. It also helps us to reduce morbidity, mortality, and the cost of healthcare. In order for us to implement preventive measures, you can't be preventing a disease that is already in the advanced stage. So it has to be something that is still in the early stages for us to be able to say we are preventing it. And then, of course, improving the prognosis of a condition of a disease, which will eventually lead to better outcomes, comes with early detection. Also, one of the other important reasons why we do screening is to improve the prognosis of such conditions. Better outcomes comes with early detection. We're able to identify high-risk population based on possible family history, those ones that are related to age, lifestyle modulations, and all of that. So at the end of the day, individuals that are screened, they are able to live healthier lives because they are picked at very, very early stages of their disease. They live longer lives while reducing the burden of the healthcare system and the healthcare costs that such conditions will have impacted on the society and the health system. There is a lot of public health benefits. It improves the life expectancy and the quality of life of the persons involved. They're able to live longer, healthier lives. Now, another major aspect of screening is that we are trying as much as possible to educate and engage the people that are concerned. That means the affected population, the at-risk population. It encourages the individuals to take active participation in their own health. Now, this is a continuum of glaucoma that I want us to briefly look at before we continue. Now, there is an undetectable disease stage for glaucoma. Then we have the asymptomatic disease stage and the functional impairment stage. At the undetectable stage, we have the initiation of the apoptosis, we have the ganglion cell death and the axon loss, and then we have the optic nerve edge change. All of these changes that we have at this stage, they are not detectable. Okay, so we can't really use any screening modality. Hello?
Please go ahead. Kindly keep your
Can you hear me, please? Any problem?
Please go ahead, sir. Dr. Kiyemi, please, you would have to unmute yourself. I think the host muted everybody.
Okay. Yes. All right, so we look at the undetectable stage, we move on to the asymptomatic stage, and then eventually the functional impairment stage. Now, our aim is not to get to see these patients when they're already developing functional impairment. The aim of screening for us here will be to be able to pick them at that asymptomatic stage. Now, so for us in glaucoma, our screening is aimed at early detection. Okay, so the asymptomatic nature of the condition, as I described in the continuum, is geared towards, you want to pick those ones with elevated intraocular pressures, the ones with optic nerve head changes, and then defective visual field features that we're able to pick at that early stage and do something about them. Prevention of blindness from uncontrolled disease progression is another major reason for us why we're screening glaucoma. And then we want to identify the high-risk populations. The targets of this high-risk population are very, very significant for us as part of the tools and modalities of helping us to increase the uptake of cases of glaucoma. Those with risk IOP, those with positive family history, racial and ethnic predisposition are important factors for us. Then screening for glaucoma also helps us in preventing or delaying the progression of the disease as a result of timely intervention. We have better visual outcomes. We're able to reduce the incidence of glaucoma blindness, to facilitate early treatment decisions in such patients, and then disease progression is monitored in them. So you can track the disease status of such patients. So screening is a whole lot of activities that are put together in order to make sure that the blindness that results from glaucoma is reduced to the barest minimum. And of course, the cost-effective intervention is also implemented in the process of screening with a lot of public health benefits. Now, let me look very, very quickly because of time at the challenges and the barriers to screening, especially in our developed country. There is increased prevalence of the disease, as was mentioned at the introduction. There is poor awareness as a result of this. There is higher blindness rates. We have low detection rates. We have poor accessibility to ophthalmic centers, varied healthcare access problems. A lot of infrastructures in our hospitals, in our centers, are not optimal the way they are supposed to be in terms of the uptake of these conditions. We have a lot of false positives and false negatives. Okay, we are already talking about under detection. And then at the same time, some of them are still being missed, maybe because of the caliber of the personnel that are involved in the screening. And then some that are not really supposed to be, that are supposed to be, not supposed to be glaucoma, are classified as glaucoma and then being treated unnecessarily. Of course, non-availability of financially viable screening programs. It has been said that glaucoma detection programs should be implemented only when we have facilities for glaucoma management in place. So there is no need of trying to maybe go to the population, go to town, screen out as many patients as possible, and we don't have what to do with them. We don't have the facility, we don't have the structure, we don't have the technicality of how to go about the management of this patient. It's a wasted effort. So we need to look at all of those factors, even as we begin to think about how do we create a glaucoma-free society, glaucoma-free world. Funding has been a major problem. Look at inadequate funding of our government hospitals. A lot of them are underfunded in terms of providing the essential materials. The equipment that we use in diagnosis are so expensive, that many hospitals cannot even afford them. Luckily, recently, some people are talking about public-private partnership, okay, in which some of these private institutions and organizations are trying to bring in some of this equipment, and then they partner with the government hospitals in order to be able to reduce the burden on the government hospitals. Now, Glaucoma Patient Association support is one major aspect of glaucoma care that needs to be well developed and improved in our society. Because through these, people are able to come together to encourage themselves on what to do, improve on information, increase the uptake for it. Now, let me look at the issue of health insurance and hospital departmental innovations. Take, for example, that a particular man or a woman, a mother or a father in the house is detected to have glaucoma, and then is supposed to and expected to bring all the other members of his family for testing. Now, you have to look at what happens to the registration of such people. In some hospital, maybe the first time registration, you have to pay 2,500 naira. You have to pay 3,000 naira. Some places you have to pay 5,000 naira. So what happens at such places now? If a man is discovered to have glaucoma, and then he has about 5 children that needs to be brought for screening at the rate of 33,000 naira, the transportation from their home to this place becomes a problem. So that means all of these factors need to come to play to help out in supporting that. The health insurance scheme, Glaucoma Patient Association, hospital and departmental innovations and advocacy. There was a case that we had in our hospital at a time in which the particular doctor, we had an operation for a patient, and after having the operation, the man was so impressed with what was happening, and then he donated some funds. Now, those are funds that can be used to help out some other patients, and we can do that with so many other patients, encouraging them, to move on with what has been done to support it. Now, a major challenge for us is how to improve the detection. Dr. Cyril, the slides are not moving again, or is it just for my side?
No, sir, they're not moving. Dr. Cyril, please, can you
Dr. Cyril, please.
address that, please?
We're on slide 18 now.
They're moving.
Dr. Cyril, are you there?
Yeah, with you. They're moving now, I don't know.
It's not moving.
It's not moving. It's back to the starting point.
The title screen.
The title
All right.
screen is where we are now.
So I'm going to stop sharing and start again. I don't know what's happening. Let me stop and start. Give me 2 minutes.
Thank you.
Okay, so is it moving now? Are we good now?
Yes, it is. It's moving.
All right. Dr. Deji, you can continue, sir. Dr.
Yes,
Kennedy.
you can continue, sir.
All right, thank you very much. So the challenges and the barriers to screening, a major challenge for us is how to improve our detection of these cases. Number one, we need to improve our health education and enlightenment. We need to improve on the opportunity screening that comes our way. And this needs to be a lot more strategic in the way we do them. And then we have to also look at high-risk group screening, in terms of the people that are above 40 years of age, ethnic predisposition, family predisposition, race intraocular pressure, and all the other factors. It's been said that prevalence of primary open-angle glaucoma among first-degree relatives of glaucoma patients is higher than what you have in the general population. So this high-risk group screening is a major factor for us. Now, educating care providers and the public can be very, very important in screening for glaucoma, because in the first instance, the people that need to be screened must be convinced that they need to come out for that screening. Education is very, very important. There's need to update the knowledge base of both the hospital workers and the public if they are to be useful in propagating information about glaucoma. That was what was found by Okomolefa et al. In a study by Agunaya et al., 5% of their respondents, they had undergone glaucoma screening, despite a large proportion of them exhibiting a positive attitude towards screening. This is also talking about the fact that you have as low as 5% coming out for screening, but their positive attitude towards it was well recorded. So why are they not coming out? Why are the other people not coming out? A lot of things needs to be done on health education in that case. So providing care close to where people live has been advocated a lot of time. It's been found that majority of the respondents in the study by Ogumola et al. In 2024, they had not undertaken any form of glaucoma screening at all. And part of the reasons put forward is because the place was far, they didn't have money to do it, the distance to get their transportation, it's their market day only once in a week that they're able to get transportation to the major centers where all of that can be done. That's a major factor, which if we look at how we can maneuver around those conditions, we might be able to improve our uptake of glaucoma cases. It was also discovered that community eye outreach, it improved access to eye care and provision of appropriate health education programs, and strengthening of the health insurance scheme, as I mentioned before, are all needed to improve the impact of CEO in glaucoma care. That's community eye outreach. That's according to Olawe et al. In 2022. So developing cost-effective screening strategies is what we need to look at. Now, how do we improve our detection rate? How do we improve our detection rate? Screening, 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 and screening is the major part. The first aspect of it is the issue of education. The second part of it is the fact that they must be able to now come out, obviously, for the screening. This screening needs to be well structured, needs to be well designed. Opportunity screening is topmost on the list in the sense that anybody coming for any form of high check is coming for allergic conjunctivitis, is coming for diabetic related eye problems, is coming for spectacle change. We have a lot of people coming for this. They should have their eyes screened and checked for glaucoma. Comprehensive eye examination is also a very, very important aspect that we can use to catch a lot of people. I advocate this that when we are having a trial system in our setup, that's like a system in which you are trying to accommodate as many patients as possible. I know some of our centers will limit how many people we are seeing at a particular point in time. That can also limit how many of them we can catch. But when we have a trial system that is run by a more experienced personnel, they're able to pick, even within the limited time that they have, to examine that patient, the one that needs further examination and treatment as the case may be. We also need to incorporate periodic eye examination into a general examination. For example, people that are entering GSS1 from primary school, as part of their general examination, they get to high clinic, they check their eyes, they are picked up in that sense. And then those ones moving from secondary school, even to a higher institution, can also be checked in order to get them at different levels. Patient needs to be empowered. They need to understand the fact that you need to take responsibility of your sight, of your health, and of this particular glaucoma. Comprehensive eye exam for them. Age periodic checks, 40 years and above, significant early annual examination of your eyes. A patient that is going for cataract, the eyes are checked before, the eyes are checked after cataract surgery, so that at any point in time, we're able to pick it as the case may be. And cataract blindness control programs have been existing for so many years. It's well established, it's well strategized. And we feel that when you put a piggy bag screening of glaucoma and cataracts together, it can also go a long way in helping us. Yes, we know that cataract screening is a lot more cumbersome, is a lot more tedious than what you have for cataract screening, but there are still ways by which you can make it a lot much easier through their intraocular pressure, through their fast, visual field analysis, fundoscopy, as the case may be. So what are the various screening methods that we have? I just wrap up with this so that we can move on to the second part of the presentation. We want to look at the visual acuity of this patient, whether you are doing a comprehensive eye screening, people that are having examination in their general ophthalmic centers, general medical centers, can also have visual acuity done. When there's a defect of it, it can also do something else to check whether there's glaucoma in this eye or not. Comprehensive eye examination with a dilated pupil, 78D, 90D examination in the clinic. You want to do their tonometry, you want to do their perimetry, you want to do their optic nerve head assessment, I want to do their retinal nine fiber layer, ganglion cell layer assessment, you want to do their macular assessment. And then we know that these days, a lot of things can also be done through telemedicine, in which what you are seeing, even in the field, we are doing a targeted screening or we are doing a population-based screening for glaucoma, whatever is being discovered in those places can be transmitted for a senior ophthalmologist, a senior glaucoma specialist to help us to interpret it and then make the screening a lot more robust. Of course, the AI will be talked about a lot more by my chief. So we just want to see how well all of these facilities can be put together in order to enhance our screening method. So in conclusion, the prevalence of glaucoma is increasing in the developing world, yet the rate of uptake of the disease is not matching up. So we must be ready to do something to hype our rate of uptake, discovering of these cases. A lot needs to be done in the area of public education. Yes, we are doing some of them at our different corners. Thank God for World Glaucoma Week that is around the corner. We're going to make a lot of noise. But the idea is I want to make so much noise that every household is having the consciousness in their mind that glaucoma exists and I need to check my eyes for glaucoma. Both the health workers, the general populace, everybody needs to be able to understand that this problem is with us, is a major cause of blindness, especially the reversible one, and so we must target it with every strength that we have. Access to facilities must be improved, and then improve funding of glaucoma care. Aggressive health education and advocacy, plus screening, whether opportunistic and high-risk screening, stands out as critical solution pathways to improving the screening for glaucoma in the developing world. Thank you very, very much for your time.
Thank you, Dr. Akinyemi, for the very lucid presentation. And without wasting more of our time, I would like to invite again Professor Nkiru Kiza-Karaiwe to please share a slide as she starts her presentation. Prof. Ma. Prof. Ma, we can see your screen, Ma, but you would need to unmute yourself, Ma.
All right. Thank you very much.
Good afternoon and welcome once again, Ma.
Thank you very much. And good afternoon, good evening to everyone on the platform in the meeting. Thank you so much to the executive of the Glaucoma Society of Nigeria for inviting me to share in this discussion. And thank you for all the running around to get this going. I want also to appreciate the first presenter, Dr. Akinyemi, for that wonderful presentation. So just, I'm going to proceed, like he mentioned, that next week, starting Sunday, we are entering the World Glaucoma Week, and we are uniting, as the theme says, for a glaucoma-free world. And today we're discussing, as part of the series of webinars, the society is putting up the novel methods of screening for glaucoma. Dr. Akinyemi has given us some background and also some insights on suggestions of what we can do. So he's also brought out the reason why we should screen and brought out different aspects, but I just want to pick out on one of the reasons that he mentioned, and that is that detecting glaucoma early is far cheaper to treat, and this is so important because it's something that we can we can elaborate on to our public, our listening public, so that it's better to detect glaucoma earlier because it's far cheaper to treat, and that is the truth. And one is also less likely to result in visual disability. Now, if you see this graph study done that shows the cost of treating glaucoma, the different stages of glaucoma. Now, if you see the first line, that's the light blue, which is the office visits. It's from the early stages down to the advanced stages. The cost is basically around the same thing. Then the visual field tests, it's also basically around the same thing, except in very early stages where it's far cheaper. And then the next costs that gets to happen, medications. We can see that in very early stages is really quite minimal, unlike in the more advanced stages. Okay, and now when it gets to the surgery level, we can see that the cost begins to increase, especially at the advanced stages. It really gets much more. And then, of course, in the very late advanced stages, at that stage, the cost of low vision services now gets added into it. Now, the study done by Ladakos Tolls brought out the costs in terms of figures. And as we can see on the screen, the mild visual impairments cost like almost 1/5 of what it would cost if it was a severe impairment, visual impairment. That's the economic burden of the glaucoma visual impairment. And so it's just advisable to diagnose this much earlier. And apart from the direct costs of glaucoma visual impairment, the indirect costs that, for instance, the time spent, if you were to quantify time spent by caregivers, it also increases with the level of visual impairment. Okay, so where a patient who has maybe 6/9 vision, might require some support, maybe excursion to the clinic, and the cost might be like about $260. For someone whose vision is worse than 660, that person is requiring much more assistance by their caregivers. And in terms of costs, that is hugely high. And so visual impairment and blindness gets high indirect costs, and due to loss of productivity on the part of the caregivers and premature mortality that gets to happen. Now on this screen, you can see the costs also of vision problems. And we can see for the whites, for blacks, and for the Hispanics. And we can see that it's worse for the blacks, as one could expect, because of the higher prevalence and more aggressive nature of the disease, and even worse in the men than in the women. Because women tend to give a bit more attention to their health more than the men do, except their wives, persuade them to pay attention to it. Now, so this study was done that where they compared prevalence between ages 70 to 74 among the whites, Hispanics, and blacks, and then after 75 and above years. So we can see how the percentage just gets to increase much more between the aged 70 to 74 and then those 75 and above. There you're having for that's about 23% of prevalence. So the older someone gets, sometimes some people, after they've done screening once, they don't bother doing it again. Say, I did it 3 years ago and I was okay. But it didn't happen this year. It could happen start next year. So how do we get a patient with a silently blinding disease to be detected? Dr. Akiemi has brought it out, is by screening. That's the only way we can detect a silently blinding disease that doesn't manifest until late in the stage of glaucoma. So now, why don't we do population screening? There are requirements for population screening. And this is WHO's recommendation for criteria for population screening. These 5 key things, they say, 1, the prevalence. The disease should be sufficiently prevalent to justify the screening. And it puts the prevalence of 1 to 2% is often considered reasonable, a reasonable threshold for population screening, but it may vary depending on some factors. Well, glaucoma, we know what the prevalence is in our own environments, 5.02% in those 40 years and above. Now, it should be of importance. So the disease should have significant health implications. We know that this has great implications because of the blindness, disability, life years that it brings about. Then detectability. The disease should be detectable at an early stage. So these are questions we need to answer. Is glaucoma detectable at an early stage? Then 4, Akiemi brought this out also, effective treatment should be available. And then number 5, cost effectiveness. The screening should be cost effective. So you want to look at the cost benefit analysis. And then so these are WHO's recommendation. But then the Preventive Services Task Force of the US and the UK National Screening Committee, concluded after their own analysis that based on their own cost-benefit analysis, that it didn't profit them. There was no concrete evidence for them to recommend population screening for open-angle glaucoma in adults in their environments. But then this study, so that's, many times the documents and information we have are the information by the Caucasians or the decision by the Caucasians. And they say, for what we know in our environment, there's no benefits. The cost outweighs the benefits in doing population screening. But we have to begin to think a little independent of that. What of us? So this study done by Ladakbo et al., looked at, it was a checking the predictive performance of a screening test that has about 73% sensitivity and 96 specificity. And so it applied it on a cohort of 50 years, people of 50 years and above, with a prevalence of 0.9%. So that is in a Caucasian population. And they found out that they got 14% true positive and 86% false positive. So when they are talking about they don't have evidence to support large-scale population screening, you can understand why their committees would come to that conclusion. But then on the other hand, let's look at where that same principle was applied to a cohort that's the same age, the same characteristics, but the difference, whereas this cohort has a prevalence of about 3.8%. And they found that they were able to get 43% true positives and 57% false positives. So, and with this results, it made at least the UK NSC to say that, and also the US committee, that glaucoma screening can be done or shows evidence of benefits, more benefits than the costs if you do it in targeted population. So you have this phrase, which Dr. Akinyemi referred to, targeted screening strategies. So you're targeting a particular population that is at high risk of having glaucoma. So now this population, this study was done in, was 3.8%. The African population, it has a basic prevalence or an average prevalence of 4.25. So when we apply this principle to it, we see that we get even a higher predictive positive value than what they have here. And when you come to populations where you have like ours, 5.02, or like in the Southeast, 7.7, then you can see that we will really have a higher positive predictive value. So, for instance, in Spain, Anton et al. Had, when he did the population screening, had like 4.1. In Enugu here, we had like 14.5 of people proportion of patients or participants who had glaucoma or glaucoma screening. All right, so the UK NSC now ended up saying that modeling suggests, and this modeling is from that study by Ladakbo et al., that initiating a screening program for a high-risk subset of a cohort age 50 years and above with an expected prevalence of POAG of around 4 to 5% rather than the 0.9% in a general population might be worthwhile. So that is their conclusion. So we ask ourselves that what's our prevalence in Africa in those 40 years and above, and we say it's about 4.25. So we ask ourselves, are we high risk? And of course, we all know the answer. Yes, we are high risk. And so do we qualify for population screening? So that's a question we need to ask ourselves and we need to answer. So do we qualify? And do we meet other, apart from prevalence, we verified based on prevalence that we qualify, but what of other requirements for population screening? Are they met? Do we, is it important? We agree. Is it detectable? Well, that's part of what we are easily detectable. That's what part of what we are talking about today at an early stage. Is it treatable? Yes, that we will take on another time, but we know we have some level of treatments that are available, but depending on the area that this is being addressed. And then is it cost effective? Yes, we've shown that it's cost effective to treat the disease at an early stage, far more cost effective than having it blind the eye. So we want to look at what screening methods are effective. Okay, like Akiemi mentioned, that we have different tests we do when we want to examine patients or screen patients for glaucoma. Okay, and so we can do any of these tests usually, which we've listed, we are conversant with. Now, so this is a meta-analysis analyzing the different methods, combination of different tools to see the one that will give us a high enough sensitivity and also a high specificity so that it reduces the false positive numbers that we have. Now, the reason why you want cost-effective methods is when you have a high false positive numbers, it overburdens the existing health structure without benefits. And that's then those who really need the health attention don't get it. So this one shows that direct ophthalmoscope gives us a sensitivity of 81% and 90% specificity. So what we do in the clinics, if we are still using the direct ophthalmoscope, or which we go out to screenings in the population with, that's the sensitivity and specificity. While checking the VCDR, which we do from the direct ophthalmoscope with pupil exam, gives us about 90% accuracy of case detection, that was a study done by Cook et al. Now, the challenge in these methods is that it has to be somebody who is trained in the use of ophthalmoscope. So if if it has to be that, then that limits how many people who can have access, because the number of people who are trained to use the direct ophthalmoscope is also limited. So if we can have now I'd like us to just see the second to the last one, which is FDP in moderate glaucoma has 96% sensitivity and 96% specificity in moderate glaucomas. And of course in advanced glaucoma is 100, but we want, if as much as possible, if we can get it early, then that is much better. Now, if we have to have other people help us, that it is not the ophthalmologist that will be doing those screenings in the community, which is what we should aim for, because at this stage we are in, the ophthalmologists are few in number, and they should be focused more on the treatment delivery of diagnosed cases, confirming and treating the diagnosed cases, and also involved in research. So going to pick up for case detection, we should be looking forward to a situation where support staff, ancillary staff, are those who will help in case detection. So that limits the use of direct ophthalmoscope. though the this little ophthalmoscope that was advertised during the OSN conference, just forgot the name now. Now they are working on it. They are working on it to be able to attach it to a phone so that even the optician in the market, the non-trained person who can use a phone, once they attach that small ophthalmoscope to it, it can capture the fundus. And when it captures the fundus, they are also trying to develop an app which can also interpret it. So if you have the vertical curve disc ratio captured on a fundus photo and is able to be interpreted by an app, then that helps us to go towards a higher detection. But let's move on. And these are some other combinations and their sensitivities. And then we see this one, the one in green, where you have the FDT perimetry with non-mediatic fundus imaging and NCT, non-contact tonometry, giving us 99.4% in specificity in terms of suspected glaucoma and 83.78% for sensitivity and a positive predictive value of 80.4 or 80.1. So, but in definite POAG, the percentages are much higher. So what other novel strategies are available? So what I discussed earlier is just the things that we have access to normally. But what are the novel strategies that are available, which most of us don't have? Now we have the OCTA, which is a non-invasive imaging of the retinal vasculature that helps to detect glaucoma-related changes. We have also the swept source OCT, that's a high-speed, high-resolution imaging for comprehensive glaucoma diagnosis. We also have the confocal scanning laser ophthalmoscopy. Now, all these imaging technologies are available and now also available in mobile form. Okay, I'm talking about the OCT actually. I've also available, we now have mobile OCTs, small handheld stuff. Then the second novel things that we have now is the artificial intelligence and machine learning. Now this deep learning based analysis. So where AI algorithms are used to analyze OCT images, detect glaucomas related changes, and one is able to say, oh, there's a problem going on here, or machine learning based risk assessments. Okay, and these models, they predict glaucoma risk, and which are based on demographic or clinical and genetic data. So we have these things, but all these things that AI related need data. Now, we have different organizations or companies, individuals who have developed artificial intelligence apps, and some who have developed some that are some deep learning things that we're able to interpret. When Dr. Akinyemi was talking about artificial intelligence or telemedicine, he mentioned about capturing fundus photos and sending them by email maybe to an ophthalmologist who would interpret. That's one phase which has been practiced for a while in different places. So you have a reading room where they've used it a lot in diabetic retinopathy, where you have a reading room where they read and interpret fundus photos. Now, that method, it's great, but it also has its own limitations in that it still needs human beings, high-level professionals to sit down and interpret the pictures. We carried out something in that regard in Enugu here, and we had an ophthalmologist who was receiving the fundus photos and the IOP measurements and doing the interpretation whether that person captured in the market had glaucoma or not. Now, but that is telemedicine. We are all now talking about moving to another level where instead of waiting for someone to interpret it, an app interprets your results for you and immediately tells you, oh no, this person doesn't have glaucoma as of today. This person has glaucoma, okay, or is high risk. And the person can now be directed to go for referred to see an ophthalmologist. So that's the place of artificial intelligence and machine learning. But all these, sometimes they require, it's genetic, we talk about genetics, but all these require data, and it's high, big data, you know. So many times we hear big data, big data. It's big data. Big data means a lot of data that helps to teach the machines how to, what is normal, what is not normal. And so the machines now become intelligent to be able to say, if they see something like this, they say, oh yes, this falls within the parameters of normal. No, this falls within the parameters of not normal. Then we also have, among the novel things coming up, biomarkers and genetic testing. So the genetic testing, we are aware of the different studies that are going on about genetics, you know, where a number have been carried out and also still being carried out in African descendants. And so they are meant to identify genetic markers associated with glaucoma. And the aim at the end of the day is to be able to develop diagnostic things, substances, diagnostic tools out of them. So that by the time that is done, it now progresses to the level of artificial intelligence that you can just, with the touch of a little drop of blood, you know, for the genetic testing, you can say the AI interprets and say, yes, this person has a risk of developing glaucoma. You know, the same goes with biomarkers. You know, now in breast cancer, there's a Nigerian who has developed an app, a marker that is able to detect with the smallest amount of blood, detect whether a particular patient has markers indicating breast cancer. You know, so these are biomarkers also for glaucoma diagnosis, and these are also part of the things that are being developed and that can now also be progressing to the form of AI. And then we have proteomic and metabolic analysis and changes associated with glaucoma that can be identified. Then we have the group of the mobile and portable devices, which is what I had mentioned earlier, using smartphones. Then we have smartphones-based visual fields. You know, the earlier slide I showed about FDP and all that. When you want to go for screening for FDP, you have to carry the machine and all that. But now on the phone, you can have the visual field done, okay? And that makes life so much easier. We've talked about the handheld OCT devices, and this makes us able to be able to have mobile health platforms where we can integrate glaucoma screening, diagnosis, and the management. Then the telemedicine, which we talked about, that enables us to do remote screening. So you can have a team of people right there in the community, in the village, who are doing these screenings, and you are seeing the results from where you are. And it's usually powered by all these things we have spoken about and with the AI. Now, I just mentioned this, this seems quite a simple thing to try out, which we are trying to try out here in our own population. The LaRoche Glaucoma Risk Calculator. Dr. LaRoche is the president of the Pan-African Glaucoma Association, where our chairman is the vice president. You know, this LaRoche calculator is a low-cost glaucoma screening calculator. It's used to determine glaucoma risk, and it uses age, uses IOP, and the central corneal thickness for the calculation. And in the tests, in the study they did, it had about 93.5% sensitivity and 91% specificity, which is quite high, and a positive predictive value of 80.5, an accuracy of 91, call it 92%. Now, this is what it looks like. So that's the calculator, looks like this, with points awarded for different phases. So if somebody is, for instance, 70 years old, that's a +3. And if the pressure is, say, 20, that's another +3. If the CCT is between 500 and 525, that is a +1. So that person is having a total of 7. So if you look to the right, you'll see that for low-risk patients, they have, or participants, they have 0 to 5. If anybody has 6 to 18, you recommend that the person have an ophthalmic evaluation as quickly as possible. So that is what that LaRoche glaucoma risk calculator is about. So the big question we have for ourselves is, as a country, what policies do we adopt regarding glaucoma screening? You know, we did a great job in the glaucoma toolkit that was done for the African region, a fantastic tool work. And then we domiciled it to Nigeria also, which is a fantastic document and tool everybody should be well acquainted with. You know, but when we go through that toolkit, we see that we didn't address the issue of screening. And I think that it's something as a country and as a society, we need to give attention to. What do we adopt as or recommend as our own way policies regarding screening? Now, there are 4 major types of screening that can be done that Dr. Akinyemi brought out: opportunistic, the first-degree relatives of glaucoma patients, so having the family glaucoma clinics, and that's a targeted screening. And then piggybacking glaucoma screening on other activities like the cataract, and then community eye screening for glaucoma as a standalone. Interestingly, this number 3 and 4, our Cameroonian counterparts are actually doing that. So they are going community to community, you know, and addressing the matter of glaucoma and cataract, screening them specifically for that because of the prevalence. Okay, so, but we know, as Akinyemi mentioned, that we must do certain things. We can't, like our theme for the Glaucoma Week talked about is uniting for a glaucoma-free world. We can't do it alone. We need public awareness campaigns and to educate. I don't know how many of us have had the experience of you're doing free screening and you have people who bring their parents to come and participate in the event because their parents have eye problem, and they register their parents and don't register themselves, you know, and they are there for the screening with their parents, but then they are not paying, and yet they didn't register. It's not costing them, you know. And how many people will say, no, nothing, I'm good, nothing is wrong with my eyes. And when you have even educated people for there to be attitudinal change often comes from what sociologists tell us, from repeated information again and again before the mind is able to accept that attitudinal change. And then it takes its time before it translates to practice. So that's a matter. Now, if you remember the type of awareness that went on for HIV/AIDS, it was everywhere, and that's where we need to get to. So we need public awareness campaigns from every side like never before. And we need to partner with primary eye care providers and integrate glaucoma screening into the primary care settings, the primary health settings, and then, of course, the community-based glaucoma screenings. We see how to collaborate and all that. So talking about that public awareness campaign, just to stress again, we need to do an intense community education, and it doesn't have to be us who must do it. How can we partner with other people in the community, in our communities, to assist in this awareness campaign? There are certain, how can we liaise with social media experts? All of us are in social media one way or the other. We can do so physically the few times we have the time. And then what of the mass media? During the World Glaucoma Week now, all of us, fantastically, we are out there creating the awareness. And after it, we are all busy people. We go back to our practices. And those who were not fortunate to hear it during that little window of the World Glaucoma Week, that's it. They don't hear about it again. So you get to see people say they never knew about anything called glaucoma. So we also, one avenue we know that is impactful is the worship places. How can we partner with the worship places to create awareness about glaucoma? These are some things that we need to look into, and as well as community meetings, because everyone needs to hear it until they own it. So in closing on that score, I want to say that we need to do awareness until we achieve the top of the mind, tip of the tongue status. Top of the mind status means that the people, when they hear about eye, they say, oh, this is an eye doctor. So, oh, glaucoma people. They let it reach a stage where the eye to the public is almost synonymous with glaucoma. That is top of the mind. So it is the topmost thing on the minds of people once you mention the eye. We need to create awareness up to that point. And then the tip of the tongue status is where it has so achieved the top of the mind that people now own it. So somebody tells his neighbor, have you checked your own eye for glaucoma? It blinds people. Oh, me, I've done my own check for this. Go and check your own. Where the public now own the condition, and they are able to be the people passing on the message to their relatives, to their community, and spreading the information. So we need that intervention. We need to do that awareness campaign. Otherwise, when we even take the screening methods, we are able, from some of the strategies Dr. Kiemi mentioned, make it available to the people in their domain, they might not take up these services. The project we did in the Enugu main market, we took screening to the people, but it wasn't free of charge. But the cost was very little, like 1,500. We say, screen your eye. That's a community that has money passes through their hands. Education was done and the screening made available. The uptake was very poor, because they feel, I can't spend my money on, nothing is wrong with my eye, in spite of the education, pre-education that is done. But education needs to come again and again and again and again until the people own it. When at that stage, if they see screening facilities made available to them, they will take it up. So on that score, I think I would like to stop and say thank you very much for listening and for the opportunity to share my thoughts on this. Thank you.
Thank you once again, Prof. A big thank you to both of our speakers for a very lucid and insightful session. I would give a very brief review of what has been said this evening so that we can take our questions and answer. Please, while I take the summary of the presentations, you can please drop your questions in the chat box. And if you would like to have a live interaction with the speakers, please kindly show by a raise of hands. Dr. Akiyemi talked about the high prevalence of glaucoma in Africa and talked about the need for targeted screening, which can help with early diagnosis. He talked about the concept of screening, the importance of screening, as well as the public benefits of screening. He also talked to us about the challenges to screening, which include poor awareness, poor infrastructure, and a poor healthcare insurance system. He also tried to tell us about the solution or the pathways to the solution for improving screening, which should include strategic screening, screening of high-risk group people, and others. Professor Karaiwe talked to us about, she started by emphasizing the need for early detection, which she explained to us affords us a far cheaper level of treatment and less visual disability. She also talked about the economic burden of glaucoma, visual impairment, and blindness. And then she also elucidated to us why we need to do a population screening in our own environment. She talked to us about the tools for screening which are available to us. And she went on to talk about the novel techniques for screening, which included the use of AI, biomarkers, telemedicine. And she also spoke to us about the La Roche glaucoma risk calculator. She talked about the types of screening also, which included the opportunistic screening, piggybacking on cataract screening, and then standalone community screening for glaucoma. And at this point, we would like to take questions from the audience. Also, please, if you would like to have to unmute yourself and speak, please kindly do a raise of hands so that we can tell you to go ahead. Good afternoon, Professor Nakayama. Please, you can go ahead and have the floor.
Good afternoon. Thank you so very much. I want to thank Dr. Akiyemi and Professor Nkiro, sorry, your name, Akaraiwe, for that high-powered presentation. That was good. Thank you so very much. We all know that getting our patients or getting people with glaucoma to the hospital, it's a big problem. Access, either for them not even knowing, it's a big problem. Yes, I want to really thank the two presenters. However, I have a question for Professor Akaraiwe, because when we take the talk in community ophthalmology on whether glaucoma screen or not, we usually agree at the end of the day that glaucoma really population screening is not a screenable if you use the epidemiological word, which is why the UK and the US studies, they agreed that yes, you cannot screen for glaucoma. Yes, we have a high prevalence. Now, provided we just limit it to that target group, which is why it is targeted screening. But when we talk about screening of diseases, you know, as you rightly put out, we see that glaucoma is not cheap to screen for, because sometimes some patients will come to the hospital, even patients who are walking to the hospital, and you'll be wondering, is this glaucoma? Is this not? You know, unlike somebody who has high blood pressure, you know that you only need to do it twice. And if the blood pressure is higher than this level, you make that diagnosis. That's a screenable disease. But with regards to glaucoma, there are too many things that are intertwined into it, and it's not cheap. A screenable disease should be cheap, it should be portable, and it should be non-invasive. So if we look at the technical aspect of it, glaucoma really, I'm talking because of the residents who will write exams and you have questions and say glaucoma is you can screen for glaucoma. Somebody will tell you, oh, you can't just use that general word. So that is just it. But targeted screening, yes, as the two speakers have said, and we still need to work harder. Dr. Akaraiwe mentioned one thing, market. Went to the market. The marketplace is the place to go, really. you have to go there. And then I also want to add the issue when we get there, when we have enough money, we can do it. These are vision hubs, whereby, glaucoma detection is now is technologically intense. If we can afford it, just get a place, put all those equipments there. You don't even need ophthalmologists. And these are the models they use in the United Kingdom now. At least I know about 2 or 3 outer posts where they just have those machines. And these are, being operated by technicians. You can even just get school sats, those who have school sats, just teach them how to operate the OCT, how to operate the non-contact tonometer, and how to operate the fundus camera, if you have fundus camera, OCT, and the visual field. All this can be done by technician. And it is then sent to a central area using AI, or even just telemedicine kind of. And doctors are there to see who has and who does not have. And this will be a free walking place for people. Let me even just go and check. Sometimes if you go for a screening in a community and you say you are checking blood pressure, some people will just walk up to you and say, I beg, help me check. Do I have high blood pressure? So that is what we will end up with. So this is where advocacy, so governments, or even we have public-private partnership, we have industries, we talk to them. We need to still move to industries. We need to talk to them, those who can help, so that we can have all these equipments. Because how many ophthalmologists are there in Nigeria? They're also busy in the hospitals, and we are not able to, even if we talk about optometrists too, in fact, now they are heavily depleted because of the Japa syndrome. Soon ophthalmologists too probably will be affected. But if we have these people, the lower cadre, who can do all this, the community eye health workers in the community to do the community screening, and we teach them the little, that ophthalmoscope you were trying to remember is the peak or the arc light, that they just shine the light. Is so bright. There I brought it out,
Yes,
and whether there is constriction or not. So these are all the things that I just want to add. But once again, I want to say thank you so very much for my governor. She's the governor for the African region, Professor Nkiru Akaraiwe, and Dr. Akinyemi. Thank you also very much for the lecture.
Thank you,
Thank you,
ma'am.
Prof. Ma. Thank you, ma'am. We have some questions in the chat box. Prof. Ma, there's a question that says, talking about allied professionals screening for glaucoma, we know optometrists can do basic fundoscopy for glaucoma. However, they go ahead to treat or give glasses without assessing progression. And some patients actually get worse. How can we draw the line between allowing our allied professionals to screen only and not treat? That question was addressed to Professor Akaraiwe.
Thank you very much. Thank you very much, Professor Onokoya, for that great input. Yes, what I was trying to remember was the arc light. That arc light is being developed for the developing countries, and it's a very cheap ophthalmoscope, but it's being developed now to be able to be attached to a phone, so that you don't have to do the fundoscopy yourself. Somebody can just, together with the phone's camera, take a picture of the fundus. And together in the new park, they are testing it out in Namibia also. The new park, they have, there's going to be a tool to measure the IOP. And then all that information will now be fed into an app that can make a diagnosis, is easy. I hope that really comes to fulfillment, and or to fruition, because that will really be a cheap, affordable tool that we can use in the communities and be able to check, screen people. So thank you very much for that. Yes, concerning the optometrists, something I had discovered is that their skill, their education in terms of glaucoma, optic nerve evaluation is not developed, and on my own, I have thought and thought. It's just, we are all constrained with time, going to relate with them, and just like in their CMEs or annual meetings, to see whatever, there are platforms, how one can make a presentation on glaucoma screening, glaucoma disc evaluation, so that they are, we can't wish them away. They are functioning in the primary eye care level. We can't wish them away. So let them be equipped to make even a proper diagnosis from disc evaluation. You know, I've had a patient who had a family history of glaucoma and was unfortunately going to see an optometrist to make sure he doesn't have, and had been with this same optometrist for years, and only presented to us when his disc was like 0.97. You know, he was almost blind by the time he came. And the man was so pained that he thought he was seeing a doctor. You know, so how do we prevent them from treating? You know, I don't know how we can stop them from treating without associating with them. You know, there's something that's when somebody is trying to compete with you, if I put it that way, you know, and you don't join in that competition, but relate calmly in such a way that then gradually the person gets to know you have superior knowledge, then they bow to you and allow you to have your way. I feel that we must connect with them. You know, I don't know that we will win this war by fighting from a distance. You know, we need to come to a table. They will treat, but if they can know the limits of their treatments, if they can know the limits of their expertise. For instance, the O&G people, when they were trying to help do programs to reduce maternal mortality, they didn't discard the traditional birth attendants. They engaged a program in which they trained them to do safe delivery and to identify those cases that should not be handled at that level. Because they invested in them in making their skill better. And then they now were able to know that there are cases that cannot be delivered naturally. You know, that equips them with the knowledge and with the spirit of cooperation to be able to say, accept some wicked ones, to send those, you know, first timers and all that who have some rich presentation and all that to go and see the gynecologist. I think we need to do something like that. I don't know where we will find the time, but that's just my own thoughts. Thank you very much.
Thank you, Prof. There's also another comment in the chat box that says, from Professor Ademola Kupola, that says, going to screen at the market. If we're going to screen at the market, what do we need to put in place to ensure treatment, considering the poor health insurance coverage we have in Nigeria? Thank you, ma'am.
Yeah, that's what, when we went to the market, it was actually a program, a project we were doing, but we also put up a clinic in the market there, you know, where we had a resident go there once a week, you know, so we had an optometrist who saw them, did visual fields for those who were picked in the screening level, and then now evaluated them in the clinic, did their pachymetries, and then did their visual fields. And then a resident went there once a week to effect the treatment at a low cost as much as possible.
Thank you, Prof. Professor Nokoyama, I can still see your hands are raised. I don't know if you want to make another comment, ma'am.
Yes, it's with regards to the optometrist. So you see, there's really nothing we can do about it. And the question came, they are allied health workers. So what we need to do, like you said, is we have to come to the table. You know, we can draw boundaries. Like in the United Kingdom, what is done is actually the optometrists who do the follow-up, you know, in the clinic. So the ophthalmologist, the glaucoma person is freed from all follow-up. Your pressure is normal, you've done CBF, you've done OCT. It's the optometrist who will review. And if the patient is stable, patient goes away from there. And then those ones that it seems they are progressing, then the optometrist refers or asks to see the ophthalmologist. So we can still work and have a win-win situation. What we need to let them know is, yes, of course, you need to sharpen your skills on glaucoma detection. Truly, as you have said, a lot of them cannot differentiate a cup disc from a non-cup. A lot of them treat physiological cupping, and you see a patient who has been on timolol for so long, and that patient doesn't have glaucoma. And even the corollary, those who have very bad disease, they still place them just on timolol, and those are the things that we frown at. So we still we need to have a meeting point where we can talk, maybe to the board of the optometrist. So at that level, if we have a meeting with them, because they also tell me, optometrists said, what is in glaucoma that they cannot treat, and we can't, it's a war that we cannot win if we set out, because how many are we? How many optometrists do you think we have? When they were 2,000 or over 2,000, we were just about 300 or 350. So you see, all we can do is for us to work together. In fact, the toolkit was designed in such a way that everybody, they have a role to play. As an optometrist, your role is there. As a nurse, your role is there. As a community health worker, your role is there. So all we need to do is to educate them and let them know that this is why we have all this. So our governor, maybe you would have to start off that in Africa, because I think it's an African problem. So for the whole of African region, how to get the optometrists together, and let us come to the table and see how we can help our patients further, so that some of them are not just going blind needlessly. Thank you very much.
Thank you, Prof. Ma. I would like to call on the chair of the Glaucoma Society of Nigeria to please give us closing remarks and round off the program for us. Professor Olawayema.
Thank you very much, Dr. Aderomu. Thank you for excellent coordination. I want to sincerely thank our professors and doctors who have contributed to this talk today. My thanks and my appreciation goes to Professor Nkiru Kizu-Akaraiwe. Thank you very much. We appreciate you. Thank you for the impressive, excellent presentation. I learned a lot, and I'm sure everyone here did as well. Thank you, Dr. Akinyemi. Thank you so much for putting that beautiful presentation together. Professor Nokoya, our past chair, thank you so much for the insights that you brought into this discussion. And we thank everyone who has been here, who has listened to us. Thank you for being here. Thank you for choosing to learn with us. We really appreciate you. We appreciate everyone. Thank you so much. And this comes from the Glaucoma Society of Nigeria. Thank you. We appreciate you all. Have a pleasant evening. Over
Thank
to
you,
you,
everyone,
moderator,
for being a part of this program.
Thank you. Bye-bye.
Thank you very much.
Thank you.
Bye.
Thank you. Remember our webinar tomorrow.
Yes, thank you, Prof, for the reminder.
Thank
we are
you.
all invited for that
Thank
webinar.
you.
Thank you, everybody.